Hey everybody, Dr. Avizo here. In this video, we're going to talk about conduction blocks. And so we're going to talk probably about the most high yield topic here, and that's going to be these atrioventricular blocks. And then we'll touch a little bit on bundle branch blocks, just because I feel like this is a topic that doesn't really get talked about very frequently, but still has some relevance. And then we'll just wrap things up really quickly, going over some of the blood supply for the cardiac conduction system. Okay, so when we're talking about atrioventricular blocks, we're primarily going to focus on blocks at the level of the AV node. So what are those blocks going to cause? Now remember, when we're talking about our cardiac conduction system, there's a few different steps, right? So you have the SA node that's going to be firing off, your initial impulse, and that's going to send that signal to the AV node. And remember, these are both going to be in the right atrium primarily, and primarily both going to be supplied by the right coronary artery, which is going to come into play in a second. And then the AV node is going to send that signal through the bundle, and then this is eventually going to go to the right branch and the left branch. Remember, there's going to be more details with that, but essentially we're talking about blocks on this slide that are happening here at the level of the AV node. Remember, if there's dysfunction at the SA node, this is typically going to present with your classic sick sinus syndrome, okay? And we'll talk about that in a moment and how that relates to the third degree AV block. But in general, in this slide, we're talking about blocks at the level of the AV node. Okay, so let's start talking about the first degree AV blocks. So again, this is graded by severity of the block. So think of the first degree AV blocks as just like an AV node that doesn't quite conduct these impulses as well. And so typically what you're going to see here is you're still going to see, remember, your P wave, think of your P wave as what's going on in the atria. That's the atrial depolarization. And then the QRS is what is happening here in the ventricles, okay? And that's your ventricular depolarization. Now with a first degree AV block, the signal still gets through. It's just a little bit harder to get that signal through. It just takes a little bit longer. So the bottom line is that there's no interruption between atrial and ventricular conduction, okay? So you're still gonna get, for every P wave, right, you're still gonna get a QRS. That's not going to change. So anything that's conducted in the atria will get to the ventricles. It will just take a little bit longer to get there. And so your PR interval is going to tend to be a bit longer for that reason. Okay, so this region is going to tend to be a bit longer. And so you can see that here. Usually this is going to be more than 5 little boxes. Remember, each of these little boxes is going to represent 40 milliseconds. And so if there's more than 5 of them, that's very classic, this prolonged PR interval. And so that should make some sense, right? Because we have a delayed signal between atrial depolarization and then that signal getting to the ventricles, because it's difficult to get that signal through the AV node. That's the whole concept. So the P intervals, the intervals between each P wave, those are going to be regular. There's going to be no changes there, right? We have a normal sinus rhythm coming from the SA node. It just simply takes longer to get the signal through the AV node. So that's important. So we have a regular rhythm. And in general, again, these are graded by severity. So you can think of this as a very low risk block. Usually, and step 1 doesn't test a ton on management, but it's still a good idea to kind of have this breakdown of things that are less severe tend to be more asymptomatic, like first degree blocks, right? This would be usually an EKG finding that's relatively asymptomatic and usually doesn't require management, okay? First degree AV block, everything that was conducted in the atria got to the ventricles. In the second degree AV block, the difference is that some signals will get to the ventricles, but not all of the signals. Okay, so in the first degree, everything got through, just took a little bit longer. Second degree, some things get through, but not everything gets through. And you can imagine the third degree will be nothing gets through. Okay, so that's where these degrees come from. So again, second degree is intermittent conduction through the AV node. So as opposed to what we saw here, right? So you're gonna have some signals that go through, but then you're also gonna have some signals that can't get through the AV node, okay, because they're gonna get blocked. So that's gonna be a second degree AV block. Now, the second degree AV block is broken into 2 categories. So we have the Mobitz type 1, which is the first category, and there's a Mobitz type 2. Sometimes the Mobitz type 1 is called the Wenkenbach, okay? So sometimes you'll just see this term used. Usually on a board exam, they'll probably say Mobitz type 1 or second degree Mobitz type 1. So what's the difference between these 2 blocks? And then, why do we differentiate them? As we're moving down here, we tend to get into this range where we get these patients to usually be symptomatic. And that usually happens right around this second degree type 2 and the third degree AV blocks. So the reason you want to differentiate the type 1 Mobitz from the type 2 is because the type 2 usually requires some management, because those patients in the type 2 can usually go on to become a 3rd degree block. In other words, once they get to 3rd degree AV block, there's no connection between the atria and the ventricles. They're independent of each other. Okay, so we'll talk about that in a second, but that's why you differentiate these two. And again, the difference between them is in a 2nd degree type 1, you have progressive lengthening of the PR interval until a QRS is dropped. So let's take a look at that. So here's your P wave, okay, so you can see your P wave, here's your PR interval, right? And then you look at the next one, you can see that it's longer. And then again, it's longer. And then what happens is, here's your P wave, right? And guess what? There's nothing here. So your PR interval got longer and longer and longer, and then you dropped a beat. So this is sometimes said to be a regularly irregular rhythm, okay? So not to be confused with something like atrial fibrillation, which is irregularly irregular, okay? So what it's saying here is the rhythm itself is irregular because you have increasing length in your PR intervals. Every time the SA node fires, you have an increased length there. So that's irregular, but it's a predictable irregularity. In other words, it's getting longer each time and then you're dropping a beat. So that's a regularly irregular rhythm. If something was an irregularly irregular rhythm, there would be no way to predict what's going to happen on the next beat. There would be no way to say, now we're going to have further lengthening of the PR interval, or we're going to drop a beat. There'd be no way to predict that in AFib, because you just don't know which one of those 500 per minute atrial signals are going to get through to the AV node. So that's the difference between irregularly irregular and regularly irregular. So just to clarify that. Now again, this is going to differentiate itself from a regular rhythm in a 1st degree AV block. In a 1st degree AV block, we just had a prolonged PR interval. It just took longer to get through. Here, the signal is going to get more and more delayed. It's going to get harder and harder to get that signal through, and then eventually it's going to get blocked and it's not going to get conducted. And then we're going to start all over again. Okay, and so you can see that starts all over again from where we started here. So that would be a type 1 block. And again, this is generally a low risk block, usually conservative management. Okay, in other words, we're not usually going to treat this medically or with a pacemaker or anything like that. Again, it's really important to differentiate this from the Mobitz type 2. So let's talk about the Mobitz type 2. So the Mobitz type 2 is, again, intermittent conduction, same thing that we saw with the type 1. They're both intermittently conducting a signal. Eventually, you might drop a signal. You might not get all of the signals from the atria to conduct like we saw here. But in this case, the cells don't kind of progressively fatigue, so to speak. You know, the PR intervals you can see here are always going to be the same. And then out of nowhere, here's our P wave. And look, we just completely miss out on conducting the QRS. So it's kind of like these signals are just sending, you know, no problem. They're not getting more and more delayed. But then out of nowhere, one of these signals doesn't conduct. And so we don't get a QRS here. So that's the big difference. You don't see this progressive lengthening. And this tends to be more severe because the AV node isn't necessarily slowing down, it's just getting blocked randomly. So the key really to differentiating the Mobitz type 1 and type 2 is just to look at the PR intervals. Is the PR interval lengthening, right? You're going to see in both cases a dropped beat, but the key is look at the PR interval. Is it lengthening or not? If it's not lengthening, if it's the same and then you just drop a beat, then that's going to be a type 2, which would be more severe as opposed to a type 1. And the way that I remember this is that the type 1, the Wenkenbach, that has a warning. Okay, so the type 1 has a warning. That W to me stands for warning. Okay, in other words, the warning is, hey, look, we're getting closer and closer to dropping a beat. This is the warning. Hey, we're going to drop a beat, and then we drop a beat. Okay, so that's how I remember that the Wenkenbach is associated with a warning, and that warning is a good thing, right? We're getting a warning before we drop a beat. That's why it's a type 1. It's less severe. We get a heads up before we drop the beat. In secondary type 2, we're just dropping beats and we don't know when, and that is more significant, okay? And again, this is also a regularly irregular rhythm because usually these beats can drop at the same place. So we might have 3 normal beats and then we drop a beat. Okay, so again, regularly irregular tends to be the type 2 block. And you can see here that this is more of a medium risk to high risk block. And so that's why these tend to be treated more aggressively. Usually, you know, you'll look in the medications. Are there any AV nodal blocking agents? And we've talked about these a few times. So the classic AV nodal blocking agents, I'll just jump to them here. Calcium channel blockers. Remember, verapamil, diltiazem, they're going to inhibit the L-type calcium channels. Those are going to be used, again, in your pacemaker potentials, in your depolarization phases. Beta blockers, again, these are going to block CAMP. The CAMP cascade will eventually cause calcium to go down right? The calcium that's used for those L-type calcium channels, so that can also affect your pacemaker potential. Now, if you're watching this and you're saying, hey, I have no idea what you're talking about right now, I don't remember what these pacemaker potentials look like, right? These curves here, if you don't remember this at all, go back, watch the conduction physiology, antiarrhythmic videos. I go through all of this in great detail over there. Now, adenosine normally activates the GI pathway, which is the inhibitory pathway, which is kind of the same thing in some ways as a beta blocker, right? Because a beta blocker inhibits the GS pathway, right? So beta blockers are going to inhibit the GS pathway. Adenosine stimulates the GI pathway. So in both of these pathways, they kind of do the same thing, and that they both are going to decrease your CAMP levels, and that's going to decrease your calcium, okay? Just to kind of fast forward to the big picture here. And when we decrease the calcium, remember, is used in the L-type calcium channels to depolarize. Okay, so you're gonna have less depolarizations, and these work at the AV node, right, to block the AV node, so there's less depolarization. Now you have to ask yourself, do I want less depolarization at the AV node when I have a block? The answer is no, you do not. You want more depolarization, right? You want that AV node to be working. If you don't want the AV node to not conduct impulses, you don't want it to not depolarize. You don't want it to be hyperpolarized, right? And so these agents can all cause AV blocks for that reason. If you have a patient that has an AV block, you don't want them on any of these medications. It's going to make it worse for the reasons we just mentioned, right? And adenosine, the other thing, remember we talked about adenosine in the antiarrhythmic videos, this drug also will increase your potassium conductance. So not only are these three drugs, all three of them, we'll just do this here, not only are all three of these drugs going to decrease your calcium current, right? Specifically at the L-type calcium channels, adenosine is also going to hyperpolarize the cell. And it's going to do this by increasing potassium efflux. Okay, so it's going to have an even greater effect. Now remember, adenosine has a short mechanism of action, like 15 seconds. Classically, the place you'll see this used in a board question is for supraventricular tachycardia. It's to break the reentrant circuit, and so things can kind of reset. Also, digoxin, we've talked about this. Digoxin has two primary effects. The first one is its effect on vagal tone. Increasing parasympathetics are going to slow the conduction through the SA and AV nodes. You don't want that, right, in the setting of an AV block. The other major function of adenosine is that it inhibits the sodium-potassium ATPase, causes increases in intracellular calcium. So you might be saying, oh, that's good though, right? Because we get more intracellular calcium, that will help my AV node depolarize, right? Because I want more calcium to be conducted through those L-type calcium channels. So it sounds good on paper, but the one thing you have to remember before you read this is that this increase in calcium is not in nodal cells. Remember, digoxin does this effect in the ventricular myocytes primarily. Okay, so this is going to act primarily in the ventricles, whereas the increase in vagal tone from the parasympathetic nervous system, that's what's going to be acting on the AV node, okay, and the SA node as well, the nodal cells. Okay, so this increase in calcium, don't get that confused. This is not calcium current increasing in nodal cells. It's increased calcium for contractility in ventricular cells. So make sure you're clear on that. And again, we go through all of this in much greater detail in the other videos. So again, AV nodal blocking agents, you want to avoid these in questions where patients have AV blocks. You do not want to give them these medications. Now, let's just go back to our blocks. So we talked about pretty much all of them. The last one here is the third degree block. So again, first degree block, everything's getting through, it just takes longer. Second degree block, intermittent conduction. Third degree block, nothing is getting through. So complete AV disassociation, complete disassociation between the atria and the ventricles, right? This is a very high risk block. Okay, so in other words, with this block, what's happening here is nothing is getting through. So when I send a signal down, it's not getting through 100% of the time pretty much. Okay, so if I look at this, right, the difference here is there's going to be no relationship between my P waves and QRS. So you can see that these P waves are kind of also jumping in between the T waves. There's really no relationship at all. But the one thing that is constant here is my PP intervals. Okay, so you can see that the interval between all these P waves is the same. And the interval between all of my QRS complexes will also be the same. Okay, so here's my QRS complexes. So all of these intervals are actually going to be the same. It's just that there's no relationship between the atria and the ventricles. The reason for that is because all of the signals in the atria are not getting through the AV node, but they're still conducting to the atria. So every time the SA node fires, every time this SA node fires, it's going to send signal to the atria, but that signal will not get through the AV node. So you might be saying, okay, well then how do the ventricles get any signal? Remember, if the ventricles are not receiving a signal from the SA node, then the AV node says, okay, look, I'm going to pick up the slack. I'm going to send a signal down. And that way, at least I can try to pace these ventricles so that so that the patient doesn't go into asystole. Okay, so the blue QRSs are a reflection of the AV node, and the red P waves here are a reflection of depolarization from the SA node. What we call this, and we talked about this in the previous video already, but what we call this is a junctional escape rhythm. So essentially what's happening here is that the AV node is escaping this block from the SA node, and it's kind of doing its own thing. So the SA node, right, the SA node might be pacing at 60 to 100 beats per minute. That's completely normal for the SA node to pace in that range. But the AV node is not going to be pacing at 60 to 100. It might be pacing at 45 to 55 beats per minute, say. So they're pacing at completely different rates. Okay. Now you can also, let's just say that the AV node is completely refractory, or it's blocked from one of these medications. It's not conducting anything. Well, remember, if the AV node is not doing its job, then we're just going to go down the circuit here. Then in that case, then the bundle will just conduct the signals, right? So if the bundle is conducting the signals down here, it's going to pace it at an even lower rate. The bundle might pace this at 30 to 45 beats per minute. Okay. Now, if it's a signal usually, and this isn't always the case, but usually if the bundle is pacing, then we call this a ventricular escape rhythm. This is all, technicality, but it's just to give you an idea of what's happening. As you start to get kind of further and further down this conduction system, what's going to happen is your QRSs are going to get wider and wider. If you're pacing most of your signals on the right side of the heart, that signal's got to get over to the left side. And so you tend to end up with wider QRS complexes as you kind of move through here. Whereas if you're conducting the signal, from the AV node, then you tend to have more narrow QRSs. Anyway, that's the general concept of what's happening. And again, it's important to remember, the really important thing is to remember these high yield causes. What are some of these things that are actually going to cause a patient to have an atrioventricular block? So ischemic heart disease is the one that's very classically asked about. And I'll go through the blood supplies to all of these different, the SA node, the AV node. It's really important to know those. But the big thing is, since we're talking about AV blocks, remember, what supplies the AV node usually? Usually, the thing that supplies the AV node is going to be the right coronary artery. Now, we talked about in a previous video, if you've been following along, there are exceptions to this, okay? But in general, if you just have to play odds here, remember, the AV node is in the right atrium. So the right coronary artery tends to supply it, which means if they presented this to you in a board question, it would usually be due to an inferior wall MI. Specifically, this would affect leads 2, 3, and AVF, right? Those are the classic leads that would be affected. If we were talking about an inferior wall MI, right, that would classically affect the AV node. Okay, so just something to kind of keep in mind. You can also see this, though, with left anterior descending artery infarct. So they'll give you some information. But again, if you have ischemia there, you have scar tissue to a region that normally conducts these impulses, that can certainly cause an AV block. And then there's some other things here. Hyperkalemia is a big one. This has to do, think about it, right? Potassium is used for a lot of the repolarization phase. And in the previous videos when we were talking about the conduction system, and also remember that potassium and hydrogen ions are very much related, right? So if you have a cell here, if this is my intracellular space and my extracellular space, you might have an acidosis on your hands, right? So if a patient has an acidosis, typically what can happen is these hydrogen ions can go through a pump, okay, in the cells. And these hydrogen ions from the blood will go into the cells, and in exchange for the hydrogen ions, potassium ions will come out. So if you have a patient that has an acidosis, those patients are also at risk for arrhythmias, and in this case, we're talking about AV blocks, because that hyperkalemia, that high repolarization potential in the blood that can eventually get to the heart, that can come from acidosis as well for this reason, right? As you have a lot of acid in the blood, it can get taken up in the cells, and then potassium can go out into the blood, go to the heart, and affect the repolarization potentials. Okay, and that can cause blocks, like an AV block, right? Because potassium is repolarization, hyperpolarization. Okay, Lyme disease is another one that's very classic, specifically Lyme myocarditis. Okay, you can get like some scar tissue there in the heart. Sarcoidosis can also do this. Infiltrative diseases like amyloidosis, endocarditis, specifically abscesses in endocarditis, acute rheumatic fever. And I don't like lists of things because then things tend to get complicated. I just like to think of things in threes. And my big three here is going to be ischemic heart disease, pretty much electrolyte abnormalities. And then I just like to think of infiltrative diseases as like one big category. Anything that can kind of infiltrate the heart. A lot of your zebras, kind of the rarer diseases, can also do this very frequently in board questions. But I kind of think of this next section as like a pocket to that. There's also the iatrogenic thing. So you always have to keep in mind, what medications are they telling you about in a board question and in real life, right? What medications are we dealing with? These are the big ones. We keep talking about these. AV nodal blocking agents. These always have to be in your mind. You have to keep track of AV nodal blocking agents and keep track of the major drugs that cause QT prolongation, which we've talked about a few times. Okay, so I would organize those in your mind because those are two categories that tend to come up very frequently.